Hello people, this is Dr. Muskaan this side and I am going to present a case in front of you. The case is all about cardiogenic shock, how I have came to the diagnosis of cardiogenic shock, what all symptoms I have appreciated in the patient. I will take you towards the journey of this case. Let's start. So here is 55-year-old male who has came to ER with the chief complaints of breathlessness and anxiety since one day. Patient came in intubated state from outside hospital. There was history of sudden loss of consciousness after bathing today morning. Primary survey was done, ABC, airway, breathing, circulation, airway. He came intubated. Breathing assessment was done. Respiratory rate was 24 per minute. SpO2 was 98% of oxygen on 50% FiO2. On circulation assessment, pulse rate was 78 per minute and blood pressure was non-recordable on arrival. Now we have checked sensorium of the patient. When we check the sensorium, it has 4 points. It can be alert or awake. V stands for verbal, P stands for pain and U stands for unresponsive. So sensorium was unresponsive. GCS score was E1 VTM1. E1 stands that he was not opening eyes. There was no response. VT stands for we cannot see the verbal response because the patient was intubated. T means tube. And M1. M1 means patient was not obeying any command of motor responses. When we were saying ki pair hilao, he was not responding any command. So there was no known comorbidities in the patient such as diabetes mellitus, hypertension, asthma, TB contact or epilepsy or any other chronic illness. On examination, the patient was lying comfortably on the bed. He was unconscious. He was not oriented to time, place, person. Vitals on arrival was 127 by 114 was his BP. Pulse rate was 65 per minute. Respiratory rate was 18 per minute. SpO2 was 100% on 100% on 30% FiO2. Temperature was afebrile. Severe parallel was present. Clubbing grade 1 was present. Edema, lymphadenopathy and cyanosis was absent. On systemic examination, respiratory examination was done. So there was shortness of breath, difficulty breathing, anxiety, fatigue. These all are the signs of pulmonary edema. And for the chest X-ray has also supported our diagnosis, which shows pleural effusion. When I have seen the investigation picture of this patient, hemoglobin was 11 gram per dl. That means patient is anemic. TLC was 29.69. That shows leukocytosis, and leukocytosis makes me to think about infection. Platelet was normal. They were 2,11,000. PT, prothrombin time was increased. That was 19.6. Normal stands between 11.5 to 15.5 minutes. INR was normal. That was 1.42. So from CBC, I have gained the points that patient is anemic, leukocytosis and increased prothrombin time. Further, I have seen his KFT picture in which I have seen there was increased urea, creatinine, hyperglobinemia was there, hyperuricemia was there, hyperphosphatemia was there, and there was decreased AG ratio, my dear friends. So after seeing his KFT picture, a thought came in my mind that it might be AKI. So I calculated creatinine clearance of the patient, and there is one formula to calculate the creatinine clearance. That is, because he is male, the formula is 140 minus age into weight divided by 72 into serum creatinine. And when I calculated the value, it was 28.4 ml per minute. So this value lies between range of 15 to 29 ml per minute, which is stage 4 of CKD. That means there is severe kidney infection in the patient. So yes, this was discovered from this patient. Other tests such as dengue, NS1 antigen test, IgM and IgG test was negative. On peripheral smear for malaria, no malarial parasite was seen. Typhoid, IgG and IgM were negative. On urine examination, routine microscopy examination, glucose was present in urine, that is glucosuria. Protein was present in urine in trace amounts. Troponin I plus test was done, which shows 8.36 nanogram per ml. That was on arrival, but today it shows 2.36, and normal range of it lies between 0 to 0.04 nanogram per ml. And when it is increased, troponin I plus, it shows that there is cardiac damage. Troponin I was done, that was 2.65, which is also sensitive for myocardial cell injury. When I've seen the EBG of the patient, it shows metabolic acidosis with hagma, and sugar levels were also 141 mg per dl, which is more than 120 mg per dl. So there are some signs of DKA, but like metabolic acidosis is there, your glucose is there in the urine, and sugar is also increased to some limits. So further, I have seen the sepsis protocol of this patient. I have seen SIRS. In that, we see 5 parameters in that. That is temperature, your respiratory rate, your heart rate, your WBC, and your PCO2. And I have seen there was leukocytosis and hypocarbia. So there were 2 SIR plus infection was also there. So it means there is sepsis. And further, lactate level was also increased. It was 4.5 millimole per liter. And there were signs of end organ damage such as kidney functions deranged. जब मैंने देखा echo का report, there was impression of coronary artery disease, diastolic dysfunction grade 3, severe LV dysfunction with left ventricular ejection fraction 25%, mild to moderate MR and mild AR. MR is mitral regurgitation and AR is aortic regurgitation. So from this I have confirmed that severe sepsis present है, क्योंकि severe sepsis देखने के लिए आपके पास 4 points होने चाहिए mainly. Sepsis हो, जो sepsis कैसे देखते हैं, 2 SIR के points और infection. Sepsis हो, lactic acid का level बड़ा हो और end organ damage के signs आपके पास हो, साथ में hypotension हो. In my case there was no hypotension, but yeah, severe sepsis है patient को. Further, there was septic shock. Why septic shock? Because severe sepsis with persistent signs of end organ damage is present. Lactic acid का level बढ़ा हुआ है. Chest X-ray पे pleural effusion है. ECG पे ST depression है. And further, to conclude my all history, I have seen the signs of cardiogenic shock. Cardiogenic shock is when जब pulmonary edema भी present हो और आपका systolic blood pressure 90 से कम हो. There was systolic blood pressure was 115, I think so. Let me confirm, 127. So it was not 90 से कम, but pulmonary edema तो present था, plus sign present थे cardiogenic shock के, जैसे fatigue, altered mentation. Altered mentation मैंने कैसे देखा? GCS score low था. Cool extremities थी. When I have touched his feet, they were cool. Pre-renal failure, वो भी आपने देख लिया, पूरा KFT का report भी arranged है. Further, I have appreciated narrow pulse pressure. Why narrow pulse pressure? Because कैसे देखा मैंने narrow pulse pressure? Pulse pressure is your systolic blood pressure minus diastolic blood pressure. So that was 127 minus 114, which comes out to be 13. And जब 30 से 40 तक होता है तो वो नॉर्मल होता है, 40 से ज़्यादा होता है तो वो वाइड एंड पल्स प्रेशर होता है, और 25 से कम होता है तो वो नैरो पल्स प्रेशर होता है. Further, I have also appreciated pulses alterance. Pulses alterance क्या होता है? Arterial pulse with alternating strong and weak beats. I will attach that video of pulses alterance which I have appreciated in the monitor at the end of this video. So from all this, I have concluded that this patient has CKD stage 4 with cardiogenic shock, with sepsis and with septic shock. I have really enjoyed working on this case because I have never seen the patient of cardiogenic shock before, but to my surprise, all the symptoms of cardiogenic shock was present in that patient. And the treatment of cardiogenic shock is that patient should be on inotropes such as dobutamine, vasopressors such as your NORAD, and that's all. I hope you have also enjoyed listening to the history of the patient. Dr. Muskaan Bansal is signing off now.